Well, usually we start treatment with any of these tyrosine kinase inhibitors, and around between 9 to 12 months, patients start to develop resistance to these agents with new resistant mutations, and the patients start to clinically fail treatment. So we need to change treatment. So it's usually, most studies is between 9 to 12 months. On treatment, 50% of the patients will start to fail.
The decision to switch therapy on a patient who is EGFR mutated, who's developing progression, is complicated. And really progression for a patient who's EGFR mutated is heterogeneous. Some progression is small, in which the tumor may be growing ever so slightly and the patient's asymptomatic. For those patients, I may just try to continue the tyrosine kinase inhibitor. If the patient's doing well, they have a small amount of growth on their scan, but yet doing all right otherwise, I think that's really a time to consider continuing. For a patient who's developed oligometastatic disease, where the overall burden of disease is stable, but one new spot is growing, again, I think we have reasonable data that we can address that spot with either stereotactic radiosurgery or local ablative therapies and continue the TKI. I think the decision to switch to a new drug is dependent on a few things. One, the pace of growth of the cancer. Two, the presence of symptoms that the patient may be having. And then three, most importantly, is the presence of a T790M mutation. All of those things should be factored in, but there has to be a lot of critical thinking at progression. I've always, when I talk to my fellows, I say, the upfront decision is very easy. For a patient who's EGFR mutated, who's stage 4, choose your TKI of choice, either erlotinib, afatinib, gefitinib. But then when progression occurs, that's where a lot of hard decisions have to be made that aren't so clear-cut and require some critical thinking.
The patients have a very good quality of life nowadays with target therapy, like these TKI inhibitors. So if the patient develops one single metastasis, maybe in the liver or in the adrenal gland, there is now the opportunity to do a stereotactic radiation therapy to control that area. So the patient may still benefit for more time with a tyrosine kinase inhibitor without need of change. We call that oligometastatic disease. Of course, if the patient is on one of these tyrosine kinase inhibitors and the patient develops 10 new metastases, it's more scary because you don't want to delay change in treatment. So that's why this concept of oligometastatic disease is more or less new in oncology, and we try to keep the patients in the same treatment as long as the patients are developing minimum progression, meaning 1, maybe 2 lesions, and these lesions can be easily controlled with stereotactic radiation, for example.